Okay, this is Dr. Rutledge dictating the mechanism of action for the mini-gastric bypass chapter. This is part 5. What about the mini-gastric bypass and the mechanism of action with restriction versus restriction with obstruction versus restriction without obstruction? Okay, in short, what we're going to talk about, the next section, the mini-gastric bypass surgical treatment of obesity and diabetes is, number one, based upon non-obstructive restriction, reasonably high fatty food intolerance and intolerance of sweets, liquid calories, and bulky foods and large volumes of foods, with minimal malabsorption and a significant decrease in hunger, enforcing overall the equivalent of a Mediterranean-type diet. In one series of over 2,000 patients, Dr. Rutledge surveyed his patients, noticed that using a visual analog scale, preoperative hunger decreased from 7.4 out of 10 to 3.7 out of 10 postoperatively. So there's a significant effect on the desire to eat. To understand the mini-gastric bypass, it's important to understand a basic feature of general surgery called the post-gastrectomy syndrome and the symptoms that occur in a patient who undergoes a partial gastrectomy. And these include a variety of metabolic changes, such that diabetic patients often have resolution or significant improvement in their diabetes because of duodenal exclusion. They can face dumping syndromes based on the loss of the stomach volume and loss of the pyloric sphincter and potentially interference with vagal innervation. Essentially, all of the dumping syndromes are related to rapid gastric emptying into the small bowel, and there are two primary components of dumping, early or late, although there can be a mixture of symptoms, and these vary tremendously based on the patient, the creation of the gastrectomy and the gastrojejunectomy, and the type of meals and other factors. Early onset dumping usually occurs between 15 to 30 minutes after dinner, after the meal. There's a rapid shift of extracellular fluid into the small bowel after the food moves quickly through the gastric pouch into the small intestine. And because of the hyperosmolar nature of the food, it pulls fluid rapidly into the small intestine. This results in acute distension of the small intestine and a variety of autonomic symptoms, including nausea, vomiting, fullness, cramping, severe abdominal pain in some situations, cramping and diarrhea. And this has been studied in the previous decades, showing that of all the types of GI reconstructions, the Billroth 2 is most likely to induce these kinds of postoperative symptoms. Other symptoms include palpitations, tachycardia, and diaphoresis. Late dumping is based on a carbohydrate load, including sugar, liquid calories, etc., from the stomach into the small intestine. This rapid gastric emptying passes into the small bowel, and then there is an attendant hyperglycemia. An insulin response tends to overshoot because of the mismatch between the amount of carbohydrate and glucose delivered and the amount of insulin that is released. This leads with the hypoglycemia and hyperglycemia with catecholamine stimulation and mild to severe symptoms, including weakness, sweating, dizziness, and even syncope. Because of these symptoms, patients who have undergone gastrectomy are often recommended what we call the post-gastrectomy diet or a post-gastrectomy syndrome diet, and this is widely understood and widely used in general surgery, although it's interesting that many bariatric surgeons seem to have forgotten this particular component of our history in general surgery. The post-gastrectomy syndrome diet, including relaxing meal times, so they're not rushed. Generally, meals should be broken up into a minimum of 6 small meals per day, and the stomach should be avoided in overloading the stomach. Don't eat too much too fast, in short. The patient is instructed to take small bites and to chew well, to limit the amount of fluids taken with meal times to very small amounts, because the adding of fluids increases the rate of gastric emptying, and the rapid gastric emptying is the primary etiology of the symptoms. It's recommended that, in fact, liquids be drunk either before or after eating rather than with meals to avoid this complication. After the meal, it's recommended that the patient take a little rest or lie down. If you lie down, it's important to keep the head up because of the risk of reflux. 15 minutes or more after a meal, that slows gastric emptying. If there's activity, the gastric emptying is increased, and that increases symptoms. It's important to avoid sweets, sugars, and liquid calories because, again, this can aggravate the hypoglycemic events following the meal. Very hot and very cold foods lead to a rapid gastric emptying and can increase dumping syndrome. Post-gastrectomy can lead to intolerance of certain foods, especially, as mentioned, sweets, but also acidic foods, especially also fatty foods. Gas and bloating may occur because of interference with the normal digestive process because of the loss of the gastric reservoir and the dumping of food into the small intestine. This can lead to bloating, and is especially prominent in fatty meals, sometimes with lactose and other foods that require special attention for the stomach and the intestine to digest that food. It's important then for the patient to avoid foods that are known to cause gas and symptoms. And also it's important for the patient to be attentive when eating. That is to say, as soon as symptoms occur, a very severe progression can be prevented if the patient is attentive to the onset of symptoms and stops before more food is taken in. Another factor is with the intake of foods. Oftentimes there can be gas or bloating, and so tight-fitting clothing or frequent bending over can lead to problems. When sitting or resting following the meal, it's important to elevate the head of the bed. Sometimes caffeine in coffee, tea, or cola drinks can stimulate gastric emptying and can cause symptoms, and so in some patients it's wise to limit or avoid these kinds of sources of caffeine. Fatty foods is noted to be problematic and again should be avoided or minimized. Acidic foods such as vinegar and hot peppers can be bothersome sometimes, but again in moderation can be acceptable. And foods that are naturally laxatives that move gut function, such as caffeine, prunes, and other things, should be avoided because again that stimulation may worsen the symptoms of dumping. Spearmint and peppermint tend to dilate the lower esophageal sphincter, and so we don't want to have the gastric contents to reflux into the esophagus. So depending on the patient, this may be something that, if it's avoided, can improve the symptomatology and have a more normal diet. Carbonated beverages, because the increased pressure of the gas can lead to problems. Increased distension of the esophagus, the gastric pouch, or the bowel generally should be avoided. Alcohol can lead to problems including gastritis, reflux, and rapid gastric emptying. Sitting up after eating or remaining in a sitting position for 60 to 90 minutes, along with the advice for rest and relaxation, all go along to point out the same thing. With activity, you can increase the gastric emptying rate, and this can be problematic. And again, don't reeat. Don't eat again, especially not before bedtime. Generally, meals should be separated by 2 hours and at least 2 hours before bedtime, because as the emptying into the bowel occurs, there is limited digestion because of the rearrangement, and so many times these patients are better off avoiding eating shortly before bedtime. A variety of foods are recommended because of the bypass of the duodenum, including vitamins, minerals, and protein, and multivitamin along with calcium, iron, and B vitamins are recommended. It's important to beware of lactose and a variety of other foods that may lead to malabsorption, and by retaining different sugars in the gut, this can lead to gas, bloating, and diarrhea. And so it needs to be made clear to the patient that this is a possibility, and again can simply be avoided by modifying the diet, particularly with lactose-free dairy products, or choosing fermented dairy products, particularly yogurt. Now, with this background, and again, our general surgeon should already be aware of these things and should be unnecessary to have gone through that, but just as a reminder, we go through that. Now what we want to do is use three components to explain the mini-gastric bypass and its mechanism of action as far as the gastric pouch and the Billroth II gastrojejunostomy. Focusing again on three things: the dumping syndrome, the post-gastrectomy syndrome, and the mini-gastric bypass itself, and how these are related. And we're going to talk about good dumping and bad dumping. And of course, bad dumping and hypoglycemia occurs late after Roux-en-Y and can be a devastating complication. But we use the term good dumping because, in fact, dumping is common after MGB if you violate the principles of our dietary guidelines, which you just went through. The dietary guidelines of the mini-gastric bypass are not different than the post-gastrectomy syndrome because the MGB is not different than a post-gastrectomy patient. This is exactly the same thing and nothing unique or different. This is a patient from the previous 50 to 100 years who has undergone an antrectomy in Billroth II with some minor modifications. And so all of the things we just went through, which are on the internet, in the medical textbooks, and we should know from our basic general surgery training, are exactly the same recommendations, the same experience of the mini-gastric bypass patient, because all of them are exactly the same operative procedure. So what we want to say then is what we can see from the previous discussion is that the mini-gastric bypass and the post-gastrectomy syndrome patient are not easily able to eat sweets and sodas and carbonated beverages and fatty foods and a variety of other foods which can be classified in general as junk foods or liquid calories or greasy, fatty meals. So that what we see is when patients violate these basic principles, they receive the aversive conditioning of dumping. So if they were to try and violate the principles of the post-MGB diet or post-gastrectomy syndrome diet and drink a Coca-Cola, they will have the aversive, unpleasant, noxious stimulation of potentially nausea, vomiting, gas, distension, type 1 or even type 2 dumping. And this is unpleasant, and so the patients, in our experience, learn not to drink Coca-Cola. This is a good thing. Conversely, a green salad seems to go well. A large, fried, greasy meal causes severe discomfort and intolerance, and so patients learn that that's not a good choice. And again, what we see then is this aversive conditioning of dumping actually helps teach our patients to eat what turns out to be very close to a Mediterranean or an ideal type post-op diet. So let's go over dumping syndrome one more time so we can prepare to demonstrate how the mini-gastric bypass uses dumping syndrome and aversive conditioning, or so-called good dumping, to create the better diet after surgery. Again, post-gastrectomy syndrome, dumping, loss of stomach volume and loss of the pylorus leads to rapid gastric emptying into the small bowel, and it can be, as we talked about, early or late. This shift of extracellular fluid with rapid gastric emptying into the small bowel leads to distension, autonomic symptoms, and this has been shown in many general surgery studies to be most common after the Billroth II reconstruction. That's why the Billroth II results are better than Roux-en-Y and the sleeve gastrectomy. The symptoms: nausea, vomiting, fullness, cramping, diarrhea, palpitations, tachycardia, and diaphoresis. And so the patient who suffers with these symptoms will recognize they are associated with certain food groups and certain mechanisms and characteristics and types of eating habits. And these habits and these food groups will then act as a stimulus and a response so that they will find that a bowl of ice cream is not on their diet list. They will have these symptoms with these foods, and it guides them using negative feedback to a healthier diet. Late dumping, of course, is a carbohydrate load of sugars into the stomach, rapid gastric emptying again, hyperglycemia with an insulin overshoot, and then all of the other symptoms, mild to severe, with weakness, sweating, dizziness, tachycardia, etc. Again, what this teaches the patient is that a sugary drink, a sugary food, sometimes cookies and other junk foods, often lead to so-called late dumping, and this is an aversive event. And usually our patients learn quickly that certain kinds of foods will lead to this discomfort, and so they avoid them. Again, these are the post-gastrectomy syndrome experience. The syndrome is characterized by a lower tolerance for large meals, so our patients eat smaller meals. The rapid gastric emptying into the small intestine leads to dumping, so they tend to eat less, and they begin to notice that if they violate these guidelines, they will be a victim of very uncomfortable experiences, including heart rate, sharp drops in blood sugar levels, and tachycardia. In the early dumping syndrome, the symptoms occur after a half an hour, as we talked about, and late dumping can appear even beyond this. Bulk food component draws water into the intestine, sudden fluid shifts, and whereas late dumping is caused by reactive hyper and hypoglycemia. So what's recommended for the post-gastrectomy syndrome and for the MGB diet, summarized here, is 6 small feedings, avoiding sweets and fats, avoiding high fat and fried foods, more fresh fruit and vegetables in the diet, more dairy, excluding lactose in many cases, minimal liquids at the time. And you can see the MGB diet is not different than the post-gastrectomy syndrome diet, because the MGB induces intentionally a controlled post-gastrectomy syndrome situation in these patients. Again, what makes the MGB so good in this situation? Hint, it's the surgical technique. It's the DrRRutledge, and not like the lap band, the sleeve, or Roux-en-Y, which causes a stricture. So again, let's look over the mechanism of action of the MGB. It has a large gastric pouch compared to the ideal setup, the ideal design that's present in the band, the sleeve, and the Roux-en-Y. There's a large gastric pouch, in particular compared to the Roux-en-Y, with a wide open gastrojejunostomy. This creates non-obstructive restriction. Not that the patients face an obstruction and blockage, but just the opposite. When they eat healthy foods, they have rapid gastric emptying and relatively better tolerance, as long as they eat small amounts. Whereas large amounts of sugary, sweet, or bulky foods lead to the post-gastrectomy syndromes and either type 1 or type 2 dumping. In this case, in the MGB, as compared to late dumping syndrome in the Roux-en-Y, we have what we call a good dumping. That is, the dumping syndrome guides our patients away from pathologic eating. In addition, there's a moderate biliopancreatic bypass, not the long, massive bypass of the BPD and not the shorter bypass of the Roux-en-Y. And what this demonstrates, what this causes, what this results in, is relative fatty food intolerance. This kind of location for the bypass has been shown in animal studies as well as human studies, that when the food is dumped directly into the small intestine at this location, the proximal 1/3 of the gut, that this is not well tolerated. There's discomfort, some nausea, some distension, etc. This leads to fatty food intolerance. So patients, because of the aversive conditioning, tend to decrease the fat in their diet, and fat malabsorption only occurs when they violate this principle, putting a large fried or greasy meal into the intestine, which then results in malabsorption, discomfort, diarrhea, and sometimes steatorrhea. So again, the patients do not want this, so they modify their own diet. Again, what we say is remember your general surgery. If you want to understand the MGB, remember the post-gastrectomy syndrome diet. And as we've said several times, eat 6 small feedings, don't drink with meals, avoid fried foods, high-fat luncheon meats, sugar, sweets, etc. These are simple. It's part of basic general surgery, and that is equal to, it's exactly the same as the mini-gastric bypass. So MGB is restriction without obstruction. The gastric pouch with a wide open gastrojejunostomy is unique amongst bariatric surgery. It's intentionally designed without obstruction to allow the patient to easily eat small meals, associated with rapid gastric emptying, and so that a larger meal or certain character of foods like fats and sugars rapidly empty, and this leads in some cases to dumping foods into the jejunum, and that leads to aversive conditioning, particularly of sugars, sweets, fatty foods, and bulky meals. The type 1 and type 2 dumping then act as good dumping. They teach our patients what should be eaten and what should not be eaten. Conversely to the Roux-en-Y, there is no neogastric pouch because the gastric pouch in the MGB is an extension of the esophagus. It's a callus gastroplasty. Again, the gastric pouch in the MGB is unique. What we found is with rapid gastric emptying, a dumping of food into the mid-jejunum, the characteristic of the diet on our survey of over 3,000 patients demonstrates an enforced Mediterranean-type diet. So there's an increased intake of fresh fruits and vegetables and small amounts of high-fiber whole grains, cereals, fiber. Yogurt, lean meats, and fish are better tolerated than more greasy choices. And there's a decreased intake of sodas like Coca-Cola, fried foods, greasy meals, and junk food. That is to say, the MGB induces a healthy, almost ideal type of Mediterranean-type diet without obstruction, and this seems to be a patient population that's quite happy with this outcome. We'll end it here on slide 61. This is part 5.